Good afternoon, everyone. I'm Kimberly Chalia with PHCA. Thank you so much for joining us for today's webinar, How COVID-19 Changed Appendix Z, sorry about that, presented by Jennifer Dunlap and Linda Lewis. A few quick updates to share before we get started today. This webinar is being recorded and will be made available on the PHCA website within the next 2 weeks. The webinar has been approved for 1 continuing education credit for all attendees. For those who provided a NAB number, credits will be uploaded shortly, and we'll also share certificates with those in attendance. As we begin today, all attendees will be in listen-only mode. Please feel free to submit your questions via the Q&A icon on your screen, and we'll make sure to answer as many of those questions as possible at the end of today's presentation. Now I'll turn it over to Linda and Jennifer.
Well, good afternoon, everyone. We're actually going to take ourselves off camera so we're not distracted by movement. I'm not distracted by movement. But I just wanted to discuss, really, Appendix Z is the interpretive guidance for CMS participants in emergency preparedness. It focuses on life safety, and the changes actually came down on March 26th of 2021 and went into effect April 16th of 2021. I really don't believe that we were made aware that these changes were coming down the pike, so I wanted to make sure that we bring it to the forefront. This is the memo that came down from CMS from March 26th, and it really focuses on expanded guidance because of the emerging infectious diseases, and you will see EID throughout, which is emergency infectious diseases. It did come back later that the effective date would be April 16th, and you will see some links throughout the webinar as well for your information. I also have a resource section at the end. Although it's not feasible all the time to collaborate and build relationships with other facilities, they do encourage that. They believe that inter-facility collaborations really help to build relationships and set us up for better coverage when an emergency hits. And this is part of the CMS resources that are available. They did add some definitions or change some definitions. So a new one is community partners. That is any emergency personnel for full-scale and community-based exercises that can include the fire, police, etc., but can also include community partners that assist in an emergency, such as surrounding providers and suppliers. A full-scale exercise was actually added to. There is no specific number of entities that have to participate in a full-scale community-based exercise, but it is recommended it be a collaborative exercise. Minimally, they believe that you should have a local and or state emergency officials to help develop responses to potential threats. A functional exercise is another new definition, and there's some information there. But it is an operations-based exercise designed to validate and evaluate capabilities, multiple functions or sub-functions, or interdependent groups of functions. Typically focused on exercise plans, policies, procedures, and staff members that are involved in management, direction, command, and control functions. A mock disaster drill. This is something that we use often with our fire drills, but it's commonly used to provide training on new equipment, validate procedures, practice and maintain current skills. It will be used to determine if plans can be executed as designed. So what we have in our policy, is it possible to follow through with that? Or it can be used as a standalone tool. And then a workshop, which is another new one. For those of you who've heard of tabletop exercises, this is very similar to that. It's a planning, meeting, seminar, or practice session that establishes strategy and structure of the program. You will see that we use E tags for emergency preparedness instead of F tags through our federal regulations. So when you see these are the tags that life safety or the surveyors could cite you on. So E1, it's a response to the emerging infectious diseases and pandemics during a public health emergency or PHE. It will encompass how the facilities plan, coordinate, and respond to localized or widespread pandemics. It aligns with state and local plans. For long-term care facilities, the emergency preparedness program and its elements must be reviewed and updated annually. For all other entities such as hospitals, hospice, home health, it is every 2 years. But for long-term care, it must be annually. The program must be in writing somehow, whether it's a hard copy in a binder or an electronic file. It is up to the facility, but you do need to be able to explain to a surveyor where to find this information. The surveyor comes in and asks one of your staff members, where do you find out about a tornado drill? They need to be able to speak as to where they would find that information. This state's documentation must be kept for at least 2 years due to the fact that we have to have a minimum of 2 drills each year. They recommend 4 years of records because they like to look at the past 2 cycles. They want to look at those cycles because they want to make sure that we're not doing the same thing over and over again. So now we look at what needs to be included in the plan. And you will see FEMA, which is the Federal Emergency Management Agency, or PEMA, which is Pennsylvania Emergency Management Agency. They're very good references to have. It's all about emergency management. You want to train your staff according to any changes in the plan. So if you make any changes to your policies and procedures, make sure that staff are trained according to that. Some contracts may not be guaranteed in the event of a disaster. If you have a company who contracts to bring water to your facility and there's a natural disaster, they may not be able to get to you. So that guarantee may not be there that they can deliver your water. What is your contingency plan for that? Emerging infectious diseases. Consider having infection prevention personnel involved in the planning, development, and revisions. And some examples of EIDs are hazard waste, bioterrorism, the pandemic flu, and then your communicable diseases such as COVID-19. Some can be local, some can be community or widespread, some are population-centric. You need to look and engage with your local healthcare systems and healthcare coalitions. E6 looks at risk assessments. Although there is not a specific format of what your risk assessment needs to look like, you have to have one documented. It also needs to include pandemics and emerging infectious diseases. So it should be comprehensive to include all risks that could disrupt the facility's operations and necessitate emergency response planning. Consider a heat risk assessment. We are required in long-term care to maintain safe temperatures under E15. So that may be another risk assessment you need to look at. It's not required. Surveyors will review if the facility has a risk assessment and that it is facility-based. They will not examine whether or not it is appropriate. You know, what you're working on in relation to that risk assessment is appropriate or not. Should also look at an all hazards approach. So you see numerous risks that are there, such as conflicts, earthquakes, floods. You really need to look at all of these different risks. Categorize those risks and hazards identified by likelihood or occurrence. We had talked earlier about, Linda and I, about earthquakes, and I would put earthquakes on a low level of occurrence. However, she has experienced earthquakes here in Pennsylvania. So it is something that you kind of need to look at, be prepared for. However, you don't have to put as much effort into it, such as your trainings and stuff like that. But you should have a plan in place. Considerations for public health emergencies is your influx or need for PPE. So where are you going to get that? Considerations for screening residents, visitors, staff, your transfers and discharges. So everything that you've been having to worry about for the past 2.5 years, they want to make sure that we get this into the emergency plan. E7 focuses on surgeon staffing. We know that this is a problem all of the time. However, we need to have a general plan that will outline roles and responsibilities. So, for example, the facility incident commander may be the facility administrator. You don't have to put that person's name. You can put the title, because we know things change. And I really want to get you away from using individual names, because people do come and go. And if you don't update that, then you're out of compliance.
It's also critically important that everybody understand this whole incident command process. I think that was driven home to us certainly by the experience in the Uvalde school shooting in Uvalde, Texas. They claimed that one of the reasons they didn't go in is because nobody knew who was the incident commander. Nobody really knew who to listen to. Your team that has responsibility for taking charge immediately at the facility level when there's an incident needs to have training in the incident command system. My understanding of it is that certainly your administrator, whoever is designated in your emergency preparedness plan is certainly the incident commander until first responders arrive. You then need to know in advance, but typically what occurs is they immediately take over command of the incident. So even though you may have a very high-ranking individual in your facility that's present at the time of the emergency, they back down and they hand over incident command to the first responder and follow that incident command system. So you need to know, and your facility level incident commander needs to know, how do we do the handoff? You know, just like report between shifts. How do we do the handoff? And then all of your staff need to understand that they no longer report to the administrator during this emergency. They're now reporting to whomever the incident commander is. So please make sure that you and other key individuals in your organization are very familiar with how the incident command process works, so that we don't end up in the nursing facilities with an incident like was experienced at Uvalde.
And that's what's, really big, is you can't assume that somebody else is taking care of something. That's why it is just so important to have these things identified beforehand. And then E9, collaboration and cooperation. You need to have a process that you can have collaborative planning for an integrated emergency response. So not every detail needs to be in writing. The more detail you put in, the more chance, we set ourselves up for failure. But we need to have enough details to support verification of the process. Remember that for federal compliance, this is federal compliance, you do not need to have every detail in writing. But you need to look at your state requirements, your local requirements, and if you have any accreditation, you need to look at their requirements. We're going to look at policies and procedures. We recommend to include strategies and contingencies to support response to any disaster. Include planning for emergency events with a duration longer than expected. Really think about it. You know, we didn't think that 2.5 years later we would still be looking at COVID. So this did last a lot longer than expected. What would you do if the emergency is lasting longer?
You also want to give consideration to how you would handle multiple emergencies at one time. For example, during August of 2021, the Gulf Coast states, particularly New Orleans, had to deal with not only the COVID-19 public health emergency, but that's when Hurricane Ida came ashore, and the facilities in multiple parishes in Louisiana were faced with evacuating during the public health emergency. So if you had a situation, whatever your emergency, where you had to evacuate and you also had an emerging infectious disease, how would you, for example, transport people? You know, we typically think of buses or 9-passenger vans or something of that nature, but how are you going to pull that off if social distancing is important, or if you've got a highly contagious infection of any type? How will you do the transport? You know, who can you cohort in the bus? Who can you not cohort? You need to think of all of those possibilities for there being multiple emergencies at one time.
And have somebody that is going to monitor guidance. We know with COVID-19, the CDC was constantly changing their requirements, their recommendations. It's really important to have somebody that is going to be held accountable for monitoring that guidance so that you remain within compliance.
And one of the considerations with that is, are the requirements the same at the location where you're evacuating to as they are in the county that you're evacuating from? As we all know and remember well, during the public health emergency, there were different testing requirements depending upon the incidence of the COVID-19 infection rate within the county. So you need to address that in your policies and procedures as well. You know, again, in the Hurricane Ida situation, there were multiple parishes in some cases evacuating to a single warehouse, and that made national news, you may recall. So, you know, what testing procedure are we going to follow? Are we going to follow 7 different procedures because the residents coming into this evacuation facility are from 7 different counties, 7 different parishes? Or are we going to follow the guideline at the county where the facility that we've evacuated to is required to be following? And how do you make the transition to that different testing process?
So we look at E15, and a lot of times they would tell us exactly how many days or hours of backup supplies we need to have in the facility. They are not going to require that on a federal level right now. They're not going to tell us how many days and hours, but you do have to have those backup supplies. You want to look more at your state level and see what their requirements are. But ensure that your policies and procedures address food, water, medical and pharmaceutical needs for staff and residents. Consider volunteers, visitors, and other individuals who may shelter in place at your facility. Remember that alternate energy sources and temperatures are still of importance. So if you have any portable generators, they have to be connected to a facility's electrical circuit via a power transfer system as recommended by the manufacturer. Do not utilize extension cords. The requirements in the emergency preparedness plan will exceed the life safety guidelines.
One of the other things that you want to consider there is at your alternate evacuation site, what is the electrical capacity of that location. Again, I love learning from the experiences of other organizations that have been through disasters. And again, looking at Hurricane Ida and the evacuation that made national news, the warehouse was not able to have electrical lights on and air condition. So the staff that were there trying to care for 843 residents had to choose one or the other. And it happens that they chose electric lights rather than air conditioning. So imagine what it must have been like in New Orleans in a warehouse in August of 2021 with 843 people inside the warehouse setting. So you need to look at not only, do we have air conditioning? Some of the alternate evacuation sites are sometimes older school buildings that may not be air conditioned. You need to consider whether or not there are enough electrical outlets to run your portable oxygen concentrators, your feeding tubes. Is there a way to charge your, yeah, I'm drawing a blank, to test your glucometers. So there's a lot to consider about the capacity of the physical plant that you're evacuating to.
Now, when there's a power outage, most facilities nowadays have a swipe in and out for their staff. In the event of a power failure, sometimes those machines have a battery backup, but sometimes they do not, and sometimes the battery backup may run out as well. You need to have a mechanism to sign in and out for payroll and staff tracking systems. It's important to know what staff members are in the building in case of a disaster. Please note that if you're going to use spreadsheets for tracking purposes, have blank copies in a file, because if you have a loss of power, you're not going to be able to get them off your computer or print them. E19 looks at policies and procedures, outlining a contingency plan in the event patients require evacuations but are unable to be transferred due to a community-wide impact emergency. Say there is a true disaster in the area and the ambulance are taking people back and forth, from a disaster area to the hospital, and you no longer have those ambulances who can take your residents out of the building. What is your backup plan? And you also need to look at when there are there isn't availability at the emergency room. If you have residents who need acute care, but the emergency rooms are full, what are you going to do in that case? Can you maybe get somebody to come in-house to help triage, or what is the plan? Considerations for triage. This is looking at your policies and procedures. So you want to assess safe evacuations. Consider how to address when a resident refuses to evacuate. Under the surveyor guidance, it does tell surveyors to ask staff members, if you're evacuating and a resident absolutely refuses, how are you going to handle that situation? We know safety should be the #1 priority, and we cannot leave a person in an unsafe environment. It's just not acceptable. So what is the plan? What are we going to do to try and get that person into a safer environment? Surge planning, we need to look at emergency staffing strategies and plans for emergencies. We may be taking on people from the community or people from other facilities. So how are we going to care for them? What are we going to do for emergency staffing? We need to make sure that we're taking residents and other people in that align with our facility risk assessment. If I don't have host in oxygen, I'm not going to take people on a ventilator, most likely. So we need to look at the facility risk assessment and do not take anybody that you cannot help take care of. The main goals are to reduce transmission of disease, direct people to the right level of care, and decrease burden on the healthcare system. Most people, when there's an emergency, they go to the hospitals. Well, that may not be feasible. So you may end up taking some people into your facility because they can't go to the acute care setting.
That's particularly a risk for facilities that are hospital-based, facilities that are a unit, if you will, within the four walls of an acute care hospital or on the same campus as an acute care hospital. I remember in the 1980s, a lot of the hospital emergency rooms were on bypass because of a flu outbreak. And the hospitals were doing the best they could to move people out of acute care beds into perhaps their attached or affiliated skilled nursing facilities. So give consideration, especially if you're in that kind of a situation where you're hospital-based, hospital-affiliated. Can you take a patient that's 2 days post-op? Are your staff competent to deal with that type of patient so that an acute care bed can be opened up for someone that is coming through the emergency department?
Again, looking at staffing strategies, looking at evacuations, transfers, staffing assistance. You want to reduce morbidity and mortality, minimize disease transmission, and protect your healthcare personnel, as well as preserving healthcare system function. You also should look at volunteers, medical and non-medical. If the facility chooses not to use volunteers, you should still have a policy and procedure in the event that a volunteer were to come in and help. You have a natural disaster and it's very difficult to get some staff in. They can't get to the building, but the next door lady used to be a nurse. She's a retired nurse. You need to have a policy and procedure as to how you're going to utilize her services. If she's still has a license, will she be able to perform certain tasks? What if she doesn't have an active license anymore? What would you use her for?
What about orienting, or how might you utilize the National Guard? Now, typically, I think they're going to be in charge of deciding what role they will play, but certainly they need to have some kind of orientation to your building and your staff and the processes that are typically in place or that you intend to be in place during an emergency. So how will you deal with those types of volunteers as well?
And it's not just those people that receive pay from the facility that you need, that you're responsible for. In this case, you're responsible for everyone who is in there providing care. Transfer agreements, you do have agreements with other providers, whether it's acute care or home health or whatever. But you need to take into account your facility population and the ability for you to receive from the community. If your transfer agreement is only for a certain number of residents or for a certain acuity of resident, you have to plan accordingly for your remaining census. Who's responsible for tracking those residents? That is so important. You need to know where your residents went, because ultimately you're still responsible for them. And consider you're looking at those transfer agreements with each policy and procedure review, which would be annually. Think about how you're going to get the medications with the resident. What are you going to do about any belongings? Who's going to be contacting the responsible person or the family members and letting them know where their loved one is? These are all things to take into account. We have the 1135 waivers, and I tried to put in there what the process is. But we know with 1135 waivers, there are certain regulations that may be waived at the time. You need to be aware of the flexibilities exercised with and without the 1135 waiver. They are time limited. They only waive federal requirements, not state requirements. And sometimes they change. So initially, you know, we don't need the 3-day Medicare stay to bring somebody inpatient. Well, right now we don't need that 3-day, but I'm sure that shortly it's going to go back to you need that 3-day. They allow us to use nursing assistants versus certified nursing assistants. These things can change. It's not just a waiver that changes all regulations. There's only certain ones. And they, like I said, they are time limited. Alternate care sites, it's a broad term for any building or structure that is temporarily converted for healthcare use. How many times have you seen where a gymnasium or a fire hall, they put in all these cots, and this is where people go during a disaster? That's what an alternative care site is.
One of the things that needs to be considered, however, with the alternate care sites is especially infection control issues. You know, generally, I think the gymnasiums that we're seeing with the cots and so on are usually people from a community that's been hit hard by tornado, hurricane, something of that nature, not necessarily individuals that are care dependent. Those types of buildings do not generally have toilet facilities or hand wash facilities in the ratio that would be required in order to provide care that meets infection control guidelines. So you need to give consideration, if that's your alternate care site, how will you provide sufficient numbers of toileting facilities, hand wash facilities? For the toileting facilities, how are you going to provide privacy? Do you have sufficient screens available? And also, is the alternate care site set up with space enough between cots, beds, you know, whatever can be used, so that you can walk your residents between them? You know, again, a lot of these are lessons learned from previous emergency situations that didn't go as well as we would hope. So, you know, you still have to be in compliance with the regulatory guidance at the alternate care site. So it's a real challenge, but you need to give thought to it well in advance, of course.
E29 looks for the documentation of, the requirement for documentation of collaboration with state and local officials were removed. So they no longer are requiring us to show documentation that we implemented a collaboration, but they still want us to collaborate with those state and local officials. Also know where to find your applicable state and local emergency pandemic plans. And they want us to make sure that we have contact individual information for individuals and entities outlined within the standard. Do we have the number for our local police, our local fire station? Where are these numbers? It does not have to be an individual person that we have the contact information for. It can be the general organization phone number. You're looking at local emergency management agencies, command systems, so your fire, police, public health, state public health departments, that's really important. In your state survey agencies, if you're making a change in your facility, you need to contact your state surveyors. So make sure that you know the number to contact for them. And they also recommend federal emergency officials such as FEMA, ASPR, ASPR, ASPR Tracy. DHS, CMS. Ask for Tracy is another one that you can sign up for updates from them. Not all of them relate to long-term care, but some of them do. It gives you some good techniques, some good resources. I try to keep that in my little toolbox. It'll just give you some other ways of looking at different things so you're prepared for emergencies. And they do have regular updates. I think I get them once a week, maybe once every other week when updates come through. Communication, you need to be able to identify your primary and alternate means of communication. So primary, maybe cell phones. Well, if we have inclement weather, sometimes cell phones don't work. I was in my second day of work at a facility and we had a bad ice storm, and they were trying to get a hold of the fire company to tell them that there were wires down. Well, nobody could figure out how we were going to communicate because our systems were down. We couldn't use cell phones. Our hardwire phone, which many people don't have those anymore, it wasn't able to be used. So what was our alternate means? And that's where they want you to look at shared resources. And then looking at a facility's needs, we know now after COVID that they make us report so many different things. But we'd have to report shortages in PPE, report any evacuations or transfers, how to report if we need requests for transport assist, any loss of part or all of the facility function, any staffing shortages. All of that needs to be reported. So it is important to have somebody who would be your coordinator to determine what criteria and to whom the information needs to be reported. Identify your local and state policies also. We know that with COVID, we had federal requirements. We had to report through NHSN. We had to report through the CMS portal. We had to report to our state agency. Some counties had their own local requirements. You have to know who you're going to report to and who's going to monitor that. Also know that you need to pre-plan before an emergency to support surge planning, what your ability is. So you may be required to report how many people can you take, from what settings, what kind of PPE you have available, whether that's for your own use or maybe you need to help somebody else out, any availability of staff who may be able to assist, availability of electricity dependent medical and assistive equipment. So you may receive a call from a local agency saying, hey, we need help with, what is your capacity? What are you able to take? How are you able to assist? You need to be able to have that information available. Training, you need to have a process outlined that encompasses staff and volunteer training that complements the risk assessment. Minimally, you have to train staff on policies and procedures. Maintain that documentation so surveyors can tell that you did appropriately train and test. You may not have to train on, say you change a policy or a procedure. You can do a training on the change. You do not have to train on the entire policy and procedure, if that makes sense. You are required to conduct 2 testing exercises annually. They have expanded what kind of exercises. We will look at those, but you have to do 2. Establish a process that includes participation of staff over a period of time. So it can't always be daylight staff. You have to make sure all of your staff are readily or available. Consider exercises in the appropriate departments. So, you know, sometimes not every department has to be a part of the exercise. It may just be nursing only that needs to be aware, or if it's something chemically in the basement in the laundry department, make sure the laundry department is aware. Looking at HSEEP, it is Homeland Security Exercise and Evaluation Program. They give you some very good examples on what to look at in the building, what kind of planning, how to conduct, and how to evaluate. Your training needs to be based on your risk assessment. We can't stress that enough. That risk assessment is huge, and that's what everything should be based on. Individual-based responses, how to shelter in place, that's also important. So if you have a tornado drill, we know that we're going to shelter in place. And that includes maybe some visitors at the time. We don't want them going out and about. So how do you teach your staff to shelter in place? How are you going to manage continuity of care? If your facility is out of power for days on end, how are you going to continue to care for the residents? What are your triage processes? Transfer and discharge. A lot of this is very, very repetitive, but that should also tell us how important this really is. So the acceptable testing exercises were expanded. Most of us use mock disaster drills, being our fire drills, and we know that we need to have them on each different shift. But they also use the community-based full-scale exercises. I believe those are going to be very hard and difficult to try and complete because that requires so many additional people to be involved, trying to get everything coordinated. It's going to be difficult, but you can utilize a natural disaster, one that actually occurred, as your exercise. So something like when COVID started, we could use that as an actual community-based full-scale exercise. Your individual-based functional exercises or a tabletop exercise or workshop. It is a group discussion that needs led by a facilitator, and that facilitator may be an employee or a contractor. Again, your testing exercises should vary based on your requirements, your needs, your risk assessment. And then the intent, of course, is to provide a comprehensive testing and training exercise.
Jen, one of the community-based full-scale exercises that comes to mind is typically in April. There used to be, I believe there still is, a statewide drill that you can elect to participate in or not. And it was usually centered around a tornado. So if that is still available, as I believe it is, by all means, participate in that.
And I want to kind of focus on the fact that not everything is weather related or infectious related. We do have those fire drills, but they also are looking at stuff like active shooter response. So those are things where you can actually get the community involved. What would happen if there was an active shooter in the building? Because usually they kind of lock down, so many miles around an area. Who would communicate that to the outside? So that's why it's very, very important to kind of look into this and look at the different, Appendix Z has a lot of other examples contained within. This is more of an overview, but they do have actual examples. I also wanted to make sure that you knew not to test the same scenario year after year after year. You kind of have to get everything in order, because the ultimate goal is to find what gaps you have in your policies and procedures that you already have set up. What are we missing? What other things could we be adding? And it's so important to have an after action review, which we consider debriefing. So after you do one of your exercises, have a debriefing period to find out, what steps maybe didn't work or what things are missing.
One of the things that you can do that will support your debriefing process is assign some people during your drill just to stand back and observe. They don't participate in the drill. Their role is just to stand back and kind of get that 20,000 foot view, if you will. And then they come to the debriefing and help to describe what it was that they were seeing, what it was that was working well, what appeared not to be working well. So as you set up your drills, as you do your planning for your drills, plan to have observers. And those can be people from the community that are familiar with emergencies. You might work with your local hospital and ask someone from there to be an observer. Or you might even have family members that would be good individuals to just stand back and take a look at what's going on inside the building.
And that's the whole key about making this truly a collaborative approach. You can utilize so many different people to help you with these. It doesn't have to all be in-house. It doesn't all have to be, the police department or the fire department. You can utilize volunteers. You can utilize retirees. You can utilize visitors. That's the whole goal, is to make this collaborative and try and get as much help as possible, because we all know that when it comes down the pike and an emergency really happens, we need all the help we can get. On these two slides here, I do have some additional resources. I always find that if you can at least point me in the direction of where I can find some assistance, it's a lot helpful. So I do hope that you find this helpful in anything that you may need assistance with. And this is just looking at the state operations manual that has already changed in Appendix Z. Yeah. Do we have any questions that we need to look at?
I just put up the Q&A icon and I do not see any questions at this moment. If anyone wants to submit a question via the Q&A icon, they're welcome to do so. You are also welcome to reach out to myself, Jennifer, or Linda if you feel more comfortable asking your question in private. And if there are no questions, and I'm not seeing any coming through via the Q&A, we can wrap up today's session. And thank you so much, Jennifer and Linda, for presenting today.
Thank you for having us.
Thank you.
Thank you. Bye, guys.
Bye.
Bye.